Hello everyone, and welcome to this presentation on the HAS-BLED score. Today we will dive into this crucial clinical tool used for assessing bleeding risk in patients with atrial fibrillation. I am Docsaab and I am excited to guide you through this important topic. So, what exactly is the HAS-BLED score? Simply, it is a clinical prediction rule designed to estimate a patient's 1 year risk of major bleeding. Its primary target population is individuals with atrial fibrillation, particularly those who are on anticoagulation therapy. The score's main purpose is to help clinicians balance the benefits of stroke prevention, which anticoagulation provides, against the potential risk of bleeding. Major bleeding can manifest in various ways, such as intracranial hemorrhage, bleeding severe enough to require hospitalization, a significant drop in hemoglobin, or the need for blood transfusion. It's a critical tool for informed decision making. The HAS-BLED score is easily remembered through its mnemonic, which stands for 9 specific risk factors. Each factor contributes 1 point to the total score. Let's break them down. H stands for hypertension, specifically uncontrolled systolic blood pressure above 160 mm mercury. A represents abnormal renal or liver function. This includes conditions like chronic dialysis, renal transplant, or a serum creatinine level over 200 micromole per liter. For liver function, it refers to chronic hepatic disease like cirrhosis or significant biochemical abnormalities. S is for previous stroke history, particularly ischemic stroke. B indicates a bleeding history or predisposition to bleeding, such as prior major bleed or a bleeding diathesis. L signifies labile INRs, which are relevant for patients on warfarin and means their international normalized ratio are unstable or poorly controlled, with a time in therapeutic range less than 60%. E denotes elderly patients, specifically those aged over 65 years. And finally, D cover drugs like concomitant use of antiplatelet agents or NSAIDs or drinking excessive alcohol defined as more than 8 drinks per week. Calculating the HAS-BLED score is quite straightforward. Each of the risk factors we just discussed, if present, adds 1 point to the total. This means the total score can range from 0 to 9 points. Naturally, higher score implies an increased risk of major bleeding within 1 year. While the original HAS-BLED score is widely used, you might also encounter references to revised HAS-BLED, which sometimes uses more precise measures like eGFR for renal function or the SAMI TT2R2 score for simpler assessment. However, the 9 point system remains the most common in clinical practice. The clinical significance of the HAS-BLED score extends far beyond just assigning a number. It functions as an alarm bell, not primarily to withhold anticoagulation, but to identify patients who are at higher risk of bleeding. Crucially, it highlights modifiable risk factors. For example, identifying uncontrolled hypertension means we can intervene to lower blood pressure, thereby reducing the patient's bleeding risk and score. Similarly, reviewing concomitant drug use like NSAIDs or addressing excessive alcohol consumption can mitigate risks. The score provides invaluable guidance for patient management, promoting closer monitoring and more cautious prescribing strategies. It consistently demonstrates strong predictive power for major bleeding events with the risk of escalating as the score increases. Interpreting the HAS-BLED score is key to its utility. Generally, a score of 0 to 1 indicates a relatively low risk of major bleeding with annual risk of around 1%. A score of 2 suggests an intermediate risk, approximately 1.88% annually. However, a score of 3 or more is considered high risk. These necessitate caution and regular clinical review with annual bleeding risk ranging from about 3.74% for a score of 3 and potentially over 12% for a score of 5. It's vital to remember a key message. Even with a high HAS-BLED score, the risk of stroke often significantly outweighs the risk of bleeding. Therefore, the focus should always be on identifying and managing risk to ensure safe anticoagulation rather than prematurely discontinuing necessary therapy. In conclusion, the HAS-BLED score is an indispensable, standardized, and validated tool in the management of atrial fibrillation. It goes beyond mere risk assessment. driving proactive management by helping clinicians identify and mitigate modifiable risk factors. This allows for more informed decisions, striking the right balance between effective stroke prevention and minimizing bleeding complications. Ultimately, by integrating the HAS-BLED score into clinical practice, we enhance patient safety and provide personalized, safer anticoagulation strategies. Thank you for your attention, guys. If you have any further questions, please feel free to reach out, and please like, share, and subscribe to the Docsaab's Diary. Thank you.